Hi, my name is Jermyn. I'm going to be talking to you about pain management in neonates. Pain is often unrelieved in the neonatal intensive care units or NICUs. This is a big problem as chronic or unrelieved pain, acute pain in anyone is young or old, can have serious consequences. Some keywords to note throughout this is neonates, pain, analgesia, and comfort measures. Neonates admitted to the NICU undergo many traumatic and invasive procedures. It's said that most of these procedures are estimated to be moderately painful, and neonates actually experience about 14 of these daily. Reasons that people wouldn't give pain management or pain relief in this is some believe that newborns actually have a decreased ability to feel pain, or they won't remember, so it makes it unnecessary. Others actually are afraid of drug toxicity adverse reactions. Even the most premature neonate has the neural capacity to respond to noxious stimuli, so unrelieved pain can have long-term behavioral and physiological consequences. This can lead to functional changes in pain pathways and maladaptive pain cognition, contributing to morbidity and mortality. There are pain management tools available for use. Many do not know what they're called, where they are, or there's just nothing set up within their units for comfort measures or to relieve pain. Also, lack of time. This is an example of a neonatal pain assessment, the NPAS. Things that you would look at in babies or neonatals to show that they'd be experiencing pain are crying, irritability, the behavior, are they arousable, are they not? Their facial expressions, are they relaxed, are they obviously distressed or in pain? Extremities, and of course, vital signs. Okay. The study method. This was a descriptive cross-sectional survey. A questionnaire was approved by committees of each of the 7 hospitals it was given at within the United Kingdom, one area of the United Kingdom. The questionnaire included 7 procedural and 4 gestational categories, 8 open-ended questions, 24 fixed choice, and it was used to assess knowledge of pain assessment and management. Open-ended questions were subjected to content analysis on the basis of theoretical information. Knowledge was scored in comparison to reference model answers, and the missing answers were treated as incorrect. The 24 fixed choice questions were formatted using the Likert scale, so this is the 0 to 10 type scales, or categories such as true, false, never, sometimes, always, that sort of thing. The 7 procedures that were assessed were heel prick, venipuncture, lumbar puncture, elective intubation, arterial stabs, long line insertions, and chest tube insertions. The response rate was about 44%. 217 questionnaires returned, but only 199 were used. A majority of these questionnaires were from nurses. Inclusion criteria were all the doctors and nurses within the 7 selected NICU units within the United Kingdom. Exclusion criteria was any agency staff, so unit secretaries, aides, they were not included, or any non-employees. Independent variables included the use of the analgesias, comfort measures, the use of pain assessments, and the procedures performed. Dependent variables included the pain and the resulting physiological and behavioral consequences. Okay, ethical considerations. The study was approved by multi-site research ethic committees and research and development parties of each hospital. They were anonymous, and this was assured by not seeking signed consent. Each participant was deemed competent, an adult, and fully informed through information sheets and group presentations, and just the return of the questionnaire was taken as consent from a willing adult. Participation was voluntary. There was no bonuses for doing it or repercussions for not doing it. Oh, let me go back one, I'm sorry. Some techniques that are sometimes used to increase responses include self-addressing envelopes or remailing questionnaires. Because of time constraints, this was not available. Okay, some limitations. Any questionnaire is vulnerable to biases from social desirability and setter extreme responses. These are people that are always in these units, and just being around that daily, being around children daily might give them some sort of bias. Participants could be concerned that there would be some sort of repercussions, that there could be a threat to internal validity, such as somebody recognizing their handwriting or their place of employment and possibly getting mad if they said that there was no pain assessment available or something to that extent. There is no guarantee that these findings can be generalizable. They were assessed only within NICU units, only in the United Kingdom and only in one area of the United Kingdom. Could this be generalized to everywhere? We don't know. In accordance with the Data Protection Act, the workplace addresses were not released to the research team. So results and implications. Clinicians agreed that medication comfort measures should be used more frequently than they are. Nurses reported more frequent use of the analgesics and comfort measures. Doctors rarely perform these. Only 20%, which is about 40 out of 199, felt there was no need to omit analgesics in a neonate if you wouldn't for an adult, even though it is acknowledged that neonates feel pain to a similar or even higher intensity than adults. Doctors did not usually use comfort measures. Reasons stated for not using comfort measures was an emergency procedure, fear of adverse drug reactions, forgetting, the analgesia or IV site being unavailable, absence of a unit policy, and the excuse babies can't protest. Okay, some implications from pain assessment. Regular use of pain assessment was only reported out of 5 of 199 people. Only 5 people said that they would use some sort of assessment on these 14 noxious experiences that the neonatals are experiencing every single day. Only 79 of 137 nurses and 18 of 62 doctors reported that pain tools were even available on their units. It's only about half. 50 of 199 knew the names of the available tools, whether they used them or not. Most clinicians, stated that although they may not use a physical or written tool, they did base assessments of pain on behaviors, the alterations in vital signs, feed intolerance, and instability. This is the CRIES assessment. This is a popular one that was stated within the study. Crying requires oxygen, increased vital signs, expression, and sleeplessness. Results of training. Few clinicians even admitted to receiving training on their units during pre-registration or within their orientation period. 47% of doctors and 62% of nurses were aware of pain management guidelines on their units. This leaves about half, again, not even knowing what the guidelines are. Suggestions provided participants on the improvement in of pain education were significant. They believe there should be more staff education, that nurses should be empowered to act as advocates for these neonatal patients who can't speak for themselves. Prescription of PRN, sucrose is a popular one, for all infants, regardless of the reason for being admitted to the NICU, and audits of unit policy. Parental empowerment is also a big one with this. Parents know when their children are in pain. In conclusion, the extent of this study really noted the non-adherence to any guidelines involving pain assessment, or analgesics. This indicates that more clinical trials should be done to convince doctors that there is a potential to reduce neonatal suffering and there is something they can do to help these infants. Thank you.